Great. Thank you, Ethan, and thank you, Tom, for two amazing presentations. So before we move on to questions, I just wanted to remind you, excuse me, that in the coming days, we'll be sending a link to the recording for today's webinar via the email address that you used to register. And in addition, you'll receive a link to our Vancomycin AUC conversion toolkit, which includes a wide range of helpful resources and best practices, not only that you heard today, but also from hundreds of institutions that utilize DoseMeRx to help support their Vancomycin AUC dosing programs. Also, you can always reach out to us directly through the chat function on our website, which will connect you to someone immediately 24 hours a day, 7 days a week, who can help answer any questions or get you connected with more information about DoseMeRx. So we're going to go ahead and move on into the questions. And we, not surprising when you have a large webinar, we have about 30 or so questions and we have 6 minutes. So what we'll do is we'll just try and get through maybe as many as we can. And then after the webinar, we'll combine them and send out maybe a frequently asked questions document. So some of those folks who have submitted questions today can still get their questions answered. So I'm going to go ahead and start with the first question, which I think is probably best for Tom. Tom, do you have any thoughts on, so when you're using 2 levels as when you're monitoring with 2 levels, do you have a recommendation for populations or disease states where you may want to hold off on getting those levels? Because, in a lot of cases we may start Vanco empirically, but, we don't know if it's going to be continued. So just would love to hear maybe your perspective as well as Ethan's on how to handle those situations.
Yeah, so that, so Chrissy, that's a very good question. And I would also say that, if the audience can, I can stay on for a little bit longer after this. I'm not sure what Ethan's other commitments are to make sure we get, some of all the unique questions answered, or as many as we can. So, and this comes up all the time, and I think, Ethan, I think did a good job of, kind of setting up the scenarios as to, what to do in that empiric situation. So the one thing with the vancomycin guidelines is, I started out as, all the literature endorsing the AUC of 400 to 600 was really derived in patients with serious MRSA infections. Having said that, the toxicity curve of going above 600, probably applies across nearly all patient populations. So, your efficacy curve always, shift as a function of the patient population, bug, and MIC, but the toxicity curve is rather constant. So it's like anything else, if it's someone where you're just using it just in case, and there's a low suspicion of an invasive MRSA infection, you could probably get away with, not getting 2 levels within the first 24 to 48 hours. If there's a strong suspicion of MRSA, probably advisable. So in a situation where, all I would say is I'm actually very interested in what Ethan thinks. In a situation where, you're doing it, just in case, just to, if it is recovered, you are having an active drug on board, whatever program you pick, it's probably best to start out with just targeting maybe an AUC on the lower range. Again, I cannot tell you how low we can go. This idea that we have to get, these very high trough values or AUC values is really not rooted in the literature. I can tell you that, as long as you're above 400, it appears to be okay for MRSA. Whether that's true for VRE and other things, I don't know. It's always clinical judgment. But please recognize the reason why we do TDM is no PK model can explain more than 50% of the variance up front. If we did, we wouldn't have to do TDM. But, Ethan, what are your thoughts on that? I just think that, there's clear situations that we should do it. There's a lot of gray, especially a lot of empiric use. And then again, I think it depends on the institution. But how are you guys approaching that at your place? Ethan, there you might be on mute.
Oh yeah, sorry, I just got unmuted. So yeah, I couldn't agree with you more, Tom. I think it's going to be dependent on the clinical scenario that's in front of you. But I will say using these Bayesian programs is really a paradigm shift with level monitoring. early levels with appropriate outcomes with Bayesian dosing don't necessarily need to be repeated at steady state. That's the whole advantage of Bayesian dosing, of course, assuming the patient's clinical status remains stable. But that's not necessarily the case if you're doing trough-based dosing strategies, where maybe if you check a level early to make sure you're heading in the right direction, you're still going to repeat that level once you get to steady state. So I think it just depends.
Yeah, and the other thing I would say is with the whole 2-level is, and I think Ethan did a good job. It's really, if the decision is you're worrying about an invasive MRSA infections, it's usually just with one dosing interval that you need 2. And once you get a patient stabilized, I mean, you got enough information from that first dosing interval that you can transition to trough-only monitoring. So, recognize that it's not every dosing interval after the first one where you need to get 2 levels. It's just really early on, where you really want to get informative PK, where the second level is more value, particularly in patients where there's considerable interpatient variability in anticipated exposure profiles.
Great.
Totally agree.
We have a couple of questions that are specific maybe to AUC monitoring and different indications. So we had a question around how comfortable you feel about using a AUC of 400 to 600 for patients with meningitis and then also osteomyelitis. So if you could just share your clinical experience on those 2 topics, that'd be great.
Yeah, so I'll start out. I would be curious what Ethan's doing in his institution. From an evidence standpoint, clearly we have less data there. For meningitis, I mean, the infections always fall at the site of viable tissues, and vancomycin's protein binding. You actually, if there's good vasculature, you're going to deliver a lot of drug there. Perhaps that's a situation, you might want to target the higher end of the dose of the AUC range. Going above that is a risk versus benefit situation. But if you do want to go above it during the initial phases, I would always make sure once you get a patient stabilized to pull back, because it's unclear to me, do you need therapeutic concentrations of drugs, for the entire treatment course, or is it just really critical to get that initial burden down? Same thing with, infective meningitis. I mean, when you have inflamed meninges, drug gets in there pretty good. And actually, vancomycin does get into the CSF more so than other drugs. So same type of thing. If you want to target earlier for the first day or 2, that's clinical judgment. And the reason why I made such a big deal about, vancomycin AKI being a delayed effect, it's usually after 4 to 5 days of therapy. So the higher intensity, the prolonged exposure, is really when you see AKI. Now, if you go higher earlier and back off, there's still an AKI risk, but, every clinical situation, really merits judgment. Guidelines are just recommendations. They provide you with some guardrails, and not every patient fits into a guidelines. But Ethan, what do you think about my response? Do you agree, or am I just being too academic?
No, I think that's pretty fair too. And we also have to think about the microbiology of CNS infections, especially community-acquired ones where we're still using vancomycin. Those MICs that we think about for those organisms, such as strep pneumo, are going to be different than they are for Staph aureus. And if we really just go back to the recommendations in the IDSA meningitis guidelines, that trough of 15 to 20 is just referenced back to the 2009 Vanco guidelines, which was really expert opinion as a surrogate for an AUC above 400. So we're kind of just in a circle here where it all comes back to AUC anyway.
I have one quick question for Tom and then one for Ethan, and then we'll conclude today's webinar. So Tom, do you have any, or could you share your thoughts about using Bayesian dosing to calculate AUC in patients with acute kidney injury or fluctuating renal function?
Yeah, so that's where, so the one thing is if when I'm choosing a prior for your Bayesian estimator, I always like the one that has creatinine clearance or some measure of GFR, so it parameterizes clearance to creatinine clearance. And that gives you the ability to look at time varying covariance. So, with that, in someone who's septic and you take into account where their estimated GFR is related to their vancomycin clearance, it will provide a more precise estimate. But, clearly, incorporation or prioritizing, GFR to vanco clearance is really only as good as, serum creatinine, which we know is not a good biomarker of, underlying GFR, because you have to have such a dramatic reduction in GFR before serum creatinine increases. And actually, vancomycin in many ways levels collected in the patient is more indicative of renal function versus any of these formulas. So I would say, kind of with the next iteration of looking at vancomycin, I think this is where we begin to look at maybe looking at the relationship between the kinetic GFR calculator and vancomycin clearance and like these hemodynamically unstable individuals. But I would say the simplest thing to do is, probably do a little bit more intensive monitoring, maybe switch to continuous infusion at the ICU because, again, because that's proportional or linear pharmacokinetics, it's easier to kind of do dose adjustments there. But, they're problematic, and it's just an example of a patient population where you have not only interpatient variability to start, but also a lot of intrapatient variability as the renal function changes.
Great, thanks, Tom. Ethan, we're going to close this out. I think this is a good practical question for you. What has been the most common question that you get from your staff when you're transitioning from trough-based dosing, which they've done forever, to AUC-based dosing? And just can you kind of expand on how you've been able to address that question?
Sure. I think we've had a few commonly asked questions, but I think the root of all of those questions really do just kind of stem back to some of the assumptions that we make with first order trough-based monitoring. It really can't be applied to Bayesian-based dosing methods. So, one of our staff might be expecting one result, but the Bayesian platform is saying another, and that's not necessarily because either a first order calculator or a Bayesian-based calculator are producing inappropriate answers. They're just deriving that answer based on different methods. So we have to, at the end of the day, ultimately realize that these tools are helping us make clinical decisions. But at the end of the day, we have to use our clinical judgment in determining what we think is the right thing to do for the patient. So, I think there's any number of questions that can be asked, but I think, again, the root of those really do kind of stem back to that main issue. For us, really developing that FAQ document and those video series that we produced in terms of commonly encountered dosing scenarios and how they differ in a Bayesian-based process versus how they may have existed in the prior trough-based first-order kinetic realm.
Okay, great. Well, I think that's a good way to end today's webinar. So we want to thank all of the participants for joining today, and a special thank you to both Ethan and Tom for really a fantastic and informative presentation. So this concludes today's webinar, and thanks, and have a great day.